You're listening to Medscape's In Discussion series on esophageal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Samuel J. Klempner. Dr. Klempner is an associate professor and director of gastroesophageal medical oncology at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Relevant disclosures can be found with episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston, and welcome to this Medscape In Discussion esophageal cancer podcast series. Today we'll be talking about takeaways from ASCO 2024, which was a big year for upper GI. First, let me introduce my guest, Dr. Yelena Janjigian, who was with us for the first episode and is now returning to bring us home as well. As many of you know, Dr. Janjigian is a professor and chief of gastrointestinal oncology in the Department of Medicine at Memorial Sloan Kettering. Her research career and clinical practice are focused on improving treatment outcomes for this patient, and thanks for joining us.
Thanks for bringing me back. It's an honor to close this out.
Yes, should be fun. So lots to talk about. I'm going to start us off with a real-world case, and then we can talk about some of this data. So let's say you've got a 66-year-old woman comes in with new dysphagia, ultimately goes through workup and staging and is found to have a T3N1 distal esophageal adenocarcinoma. So historically, we used to argue there was equipoise for cross versus Flot in this population, but maybe tell us a little bit about how you've historically managed these and what you think of the question that ESOPEC was asking.
Absolutely. It's important to note that anatomy of the distal esophageal and G-junction tumors are closely linked. And a patient who's presenting with symptoms and weight loss, you really need to assess the extension of the distal esophagus tumor into the G-junction and perhaps into the gastric cardia, because it will have an impact and, will change your staging. For example, if there's a cardia involvement, that you will need to really consider doing a laparoscopy, especially if someone's presenting with weight loss and concerns for more advanced disease. We understand now that systemic disease is where the battle is lost and won for many tumors, but particularly for upper GI cancers, where even in patients who present with relatively quote-unquote early stage, overwhelming majority of them will recur within a year after initial surgery. So our staging involves a PET scan plus minus laparoscopy, high-resolution CT scan. In someone who presents with swallowing issues, you really don't need to consider an EUS. And then you need to bring this case to a surgeon that is experienced and within the DMT, try to understand if you're able to clear the margin to get a zero resection with chemotherapy alone. And the answer often is yes or maybe no. But if the answer is no, and then you feel that perhaps you need radiation therapy, I think that's when you need to pause for a second and really understand the risks here for systemic disease recurrence and understand that if R0 resection would be a challenge without radiation, that perhaps this patient is not truly resectable and you really need to prolong treatment for this patient to cure them or to offer them surgery down the line. And I know, we have Renaissance studies on the docket to discuss as well, but this is how you think about this disease, is it's a systemic illness and you need to address it as such. And ESOPEC is the first study to definitively address the question whether or not systemic chemotherapy with triplet combination with Flot will be as good in patients with esophageal cancer compared to the cross regimen. Flot, as you know, was born in Germany and came back to Germany for this study to answer the question. And it was a very important study.
Yeah, I completely agree. Sometimes I've wondered when we see in these frontline phase 3 trials that involve global populations and we see a subgroup of patients who are, locally advanced, unresectable, perhaps often enrolled more in Asia. Perhaps it's just exactly what you were saying, that they have recognized that although there's no radiographic distant disease, these patients really are unlikely to be resectable and should be managed as a metastatic paradigm. And they just see more. Maybe they've got that sense a little bit better, but I think it's a very important point. Getting back to ESOPEC. So this was exactly as you said, to litigate this question of Flot versus cross in real patients. You look at the patient population, these are people who are almost all T3/4 tumors, 80% node positive, real cancers. Tell us a little bit about your takeaway from sort of the punchline, the overall survival, which was the primary endpoint.
It was an amazing survival curve to see the 3-year overall survival difference in favor of systemic chemotherapy. And importantly, to just show that this is really the definitive way to highlight the importance of triplet chemotherapy, maximum systemic treatment over carbotaxol, which everyone knows is not enough for treatment of adenocarcinoma. We never use it for metastatic disease. Why would you consider using it for locally advanced disease where the stakes are even higher? But what I also was impressed with is the higher path CR rates and also the R0 resection rate. So it's clear to see that in hands that know how to select patients for Flot and know how to operate on patients who are getting Flot, these patients can do quite well. So this was an important milestone to reach for us as a community. And of course, there were a lot of discussion whether or not this is translatable to the rest of the Western population. And in short, it absolutely is. And we, as a community, need to improve on standardizing our approaches. And if patients feel that their doctor can't give them Flot safely, that perhaps they need to find another doctor.
Yeah, I think multi-D experienced centers, clearly where Flot and ESOPEC were conducted, they show us that, you can do this, and we're getting better at it too. I think 60-something% of people are able to receive adjuvant and over half of people are finishing. So we're getting better at giving Flot, which is what we all need to do because that's the right answer to do.
Well, the Matterhorn data showed that over 90% of patients globally in this global phase 3 study got all the peri-op cycles of Flot. And like you said, more than 60% of patients got all adjuvant Flot. So it's coming. I think the paradigm has shifted, and hopefully we will continue to build on that.
Yeah, speaking of building on this, so now we're going to say with confidence, someone with esophageal adeno, GE junction, and gastric, harmonizing the answer around Flot. I think that's very clearly a takeaway. You're now getting 50% 5-year survival rates, talking about cures. But where do you think we go from here? Obviously, elephant in the room, Matterhorn coming. Do you think we also need to explore additional pathways towards non-surgical strategies? Total neoadjuvant therapy, chemo followed by chemoradiation, etc.
Yeah, I think that's a great question. I think we would have to chip away at it slowly for biomarker-selected populations with high likelihood of complete response, certainly for MSI tumors, as we are already doing, but also perhaps for the next phase would be for EBV or high HER2-positive PD-L1 overexpressing tumors. You and I certainly can come up with a wish list of things, but I think it's for biomarker-selected population, perhaps with really close monitoring and surveillance. I have patients who are coming to me expecting that, and at least at Memorial Sloan Kettering, our patients are quite knowledgeable. And so if it's not in that discussion, they ask me why. Because organ preservation certainly is a logical transition to them, especially as they're hearing that these treatments are much more effective. I don't know if it's going to be a reality for majority of our patients, but for some, certainly it's a hope, and I think it's within our reach.
Yeah, let's bring it back to our case. I totally agree. Non-operative strategy, very high on advocacy group agendas. I think all of us being patients hear that loud and clear. So this patient, who we said was a T3N1 esophageal adeno, got Flot. Let's say their PET-CT looked great. They have a near metabolic complete response, and they asked you about non-surgical management. In June of 2024, what are you telling this patient? They still need surgery? It's still an important part of the plan?
Yeah, so we typically recommend surgery, especially in a patient who's relatively fit and went through Flot and feels okay, unless she's getting this in a setting of a clinical trial where non-operative management and the procedure for it and monitoring for it is explicitly outlined. I think there's very high probability that even if the initial endoscopy is negative, that there's going to be residual disease left in the lymph nodes or the even microscopic foci disease in the primary tumor. I mean, now she didn't have radiation, so I think there's little downside to, if she really felt like she wanted to be observed, to watching her and perhaps operating on her at a later date. But the surveillance and the follow-up is quite rigorous. And so she would have to be up for that and be compliant with the follow-up. And certainly it would have to be done with the surgeon's blessing. I have to say, I've done it on very rare occasions where it was not in patient's best interest to be operated on. And we got away with it from the cancer perspective. But if it's a fit, young-ish person, I would just feel relatively uncomfortable doing that outside of a clinical trial at this time.
Totally agree. Take-home message, ESOPEC is a positive phase 3 trial with overall survival improvement compared with CROSS. And this is now what we're obligated to do for esophageal adenomas in addition to gastric and GE junction. Let's take this case forward, let's say a year. So chooses not to undergo a surgery, and 2 years later, they present with a node adjacent to the primary tumor and one liver met. We saw some data at ASCO asking the question about surgery in stage 4 patients, which I think is another area that we hear a lot of questions about from the patient community. Tell us a little bit about the Renaissance trial and sort of what they were going after and trying to answer.
Yeah, so the Renaissance study, once again, coming out of Germany, try to address the question whether or not in patients with quote-unquote favorable disease biology, usually defined as low-volume disease, maybe retroperitoneal lymph nodes, and they also happen to include low-volume peritoneal disease, low-volume liver disease. It was a pretty broad spectrum of definition of favorable disease burden, who received Flot, so it's 3-drug combination, and without, I believe, immunotherapy, basically to send them to surgery if there's a nice response. I think it's an interesting study. You have to design a study in a way that you can at least try to standardize things, because you can't do 240 patient study with a little bit of that, a little bit of this approach. I mean, it's not enough systemic therapy that they gave these patients. I think if you're going to do it, and when we do it in our DMT, this patient's tumor really has to declare themselves as a favorable prognosis tumor. And we usually do protracted course of systemic therapy. I'm talking 6 months, 12 months. And only if there's persistent disease, as you said, in the primary tumor, do we consider surgery. So I like the idea of Renaissance. It's not how I would do it or how we do it. And even with that, I think, as you know, unfortunately, there was no benefit for aggressive surgical management because, as we said, it just goes back to systemic disease control, and just a few cycles of chemotherapy, even if the patient is responding, it's just not enough to declare itself as one of those favorable biology behaviors and tumors.
Yeah, I think important criticism, for the listeners in this trial, head-to-head comparison, the median survival for the surgical arm was 18 months, and the continuation of systemic chemotherapy arm was 23 months roughly. So negative phase 3 trial about surgery and oligomet or limited burden metastatic disease. And I agree with you. I think we need to be more careful about the selection, and 2 months of Flot, I think they got 4 doses is probably just inadequate. If you look at the subgroup analyses, there was a point made about these retroperitoneal nodes, and these are probably those patients that you mentioned before where they were borderline from the get-go is my guess. But tell us a little bit about when you do surgery in technical metastatic disease, like what is your typical approach? What do you think is the appropriate amount of therapy?
We all have those outlier patients. And obviously, when you look at survival curves for Checkmate 649, Keynote 811, any of these large phase 3 studies, there's always about 25% of patients who are alive long-term, right? 3, 4, 5-year follow-up data. Well, what I'm trying to figure out is how do we spare those patients in some way from a long-term chemo, right? It's perhaps not a curative approach, but a chemotherapy sparing approach, 1. And 2, improve their quality of life. Although I'm an optimist at heart, I realize we're dealing with very aggressive disease that's systemic in nature. So how do we improve patients' quality of life, long-term survival, and kind of minimize side effects? And so that's the axioms I have in mind as I'm trying to decide for each individual patient. And we're discussing, other cases at DMT. How can we help this person? And it comes down to amazing disease control systemically, clearance of peritoneal disease, no more liver mets, RP lymph nodes melted away, et cetera, but also, do they still have their primary tumor in place? And am I worried about it down the line becoming a major player and causing quality of life issues for this patient? Can they survive an operation? Will they be able to go on to receive systemic therapy after if I ever need them to? So if the primary tumor I'm worried about down the line is when I recommend surgery, and our surgeons are quite skilled, so I know they're going to get them through this operation without too much fallout and morbidity and mortality. So that's how I think about it.
Yeah, it's rare that systemic therapy will completely eradicate a primary tumor. The rates of complete responses in systemic disease are just low. I have taken to adopting, and maybe I learned this from you, if someone has excellent response after 6 months, assessing the primary tumor directly, it's a nice piece of data to stratify people on that future trajectory. Let's take the same patient and let's say they do not undergo a surgery for metastatic disease. Ultimately, they're on, let's say, FOLFOX alone. This was sort of a scenario that the ARMANI trial investigated. And just briefly in the last couple minutes, this was a question about early switch maintenance versus continuation of frontline therapy in patients who did not get checkpoint inhibitors. So continuing FOLFOX or CAPOX versus early switching arbitrarily after essentially 3 months. What do you think of the data? I mean, technically a positive study by the investigators, and kudos to them for doing the study.
Well, a couple of things. First of all, agreed. Very cool idea and design. But I was a little bit sad about how poorly the patients on the FOLFOX arm did. If you just keep going with FOLFOX, even if someone has stable disease and response, just seeing this data of progression-free survival of less than 4 months was a little just shocking and upsetting. And again, highlights the importance of biomarker selection and highlights that all of these dogmatic approaches to should we test PD-L1, who should we test for PD-L1, what if the PD-L1 is inconclusive, these patients should or should not receive immunotherapy. So this study highlights what the options are outside of targeted therapies in first-line setting, and it's sobering. This data is important for two reasons. One, because when you see a patient in the clinic and they're having maybe some symptoms and you're not sure if it's true progression and the scan is inconclusive and you're trying to be positive and downplay it to the patient, I wouldn't do that anymore. I think it's clear that if there's some clinical suspicion or radiographic or one of the other, you should just switch therapy. You will do your patients a better service and they will be more likely to be disease-free and progression-free. So don't save all your cards for the next move. Just take the step and change the treatment. I think that's what the ARMANI study taught us. The concept should apply irrespective of what the first-line therapy is, because it's clear to us that we're not treating enough patients with second-line therapy, right? Probably globally less than 50% of patients get second-line therapy outside of tertiary cancer centers. Certainly, even in tertiary cancer centers, not enough patients get third-line. And so ARMANI shed light on this and I think helped us understand why. And this is the reason. Follow your patients closely and switch therapy early.
Yeah, I completely agree. That was my take home as well, is, we really need to expose people to all of our approaches. And we all have that clinical sense when someone's on maintenance 5FU or 5FU Nivo and their symptoms are creeping up. There's some equivocal radiographic findings, totally agree. Thank you very much. And thanks to everyone listening. Today we were talking to Dr. Janjigian. We heard about improvement in survival with Flot in esophageal adenomas from ESOPEC. We heard about limited and no survival advantage to surgery in stage 4 patients, and then some interesting data about switch maintenance. Please take a moment to download the Medscape app to listen and subscribe. This is Sam Klempner for the Medscape In Discussion Esophageal Cancer podcast, and thank you again.
Thanks for listening to Medscape's In Discussion Esophageal Cancer podcast series with our host, Dr. Samuel J. Klempner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on esophageal cancer.